This is a presentation on Bankart repair. For additional videos, please visit our website at OrthoNations.org. Today we will cover basic anterior-inferior labral repair and helpful techniques. Bony landmarks include the acromion, AC joint, clavicle and coracoid. The posterior portal is located 2 cm inferior and 2 cm medial to the posterolateral corner of the acromion. The anterior portal is directly anterior to the AC joint. The low anterior portal is inferior and lateral to the high anterior portal, and will allow access to the lowest aspect of the glenoid. After a view from the posterior portal is obtained, a high anterior portal is established. Confirm position with an 18-gauge spinal needle. It should enter the joint at an almost vertical angle just anterior to the biceps tendon. Keeping this portal high and distanced from the low anterior portal will allow more room to work within the shoulder. A cannula is placed through the anterior portal. A shaver can be used to enhance visualization by removing joint fluid and soft tissue. Here you can see the anterior-inferior labral injury which has retracted medially. This is typical for a chronic labral injury. It is important to examine the joint for coexisting pathology. Hill-Sachs lesions and posterior labral injuries are often identified. In this case, the posterior labrum is intact. To begin addressing the anterior labral pathology, an elevator is used to elevate the medialized labrum from the anterior glenoid neck. The labrum should be freed medially until fibers of the subscapularis are visualized. Next, a shaver is used to debride non-viable soft tissue, and expose the bony surface of the anterior glenoid. A low anterior portal is now established. This portal should be low enough to come just above the subscapularis tendon, and lateral enough to facilitate drilling without skiving across the glenoid surface. Using soft tissue dilators over a switching stick will aid cannula placement and protect soft tissue. To assist with repair, a temporary tension suture may be placed to elevate the labral tissue into better position for repair. In this technique, a suture passer is used to pass a PDS monofilament either deep to or within the tissue to be retracted. The monofilament is then advanced at the glenoid rim and retrieved through the superior portal. Next, the suture passer is removed and opposite PDS limb retrieved through the high anterior portal. The high anterior cannula is then removed over a switching stick and replaced with the PDS now outside of the cannula. The suture can now be clamped and variably tensioned to assist with future suture passing. Now that the labrum is in better position, anchors can be placed. To begin, the first anchor is placed through the low anterior portal on the lowest aspect of the glenoid rim. Care should be taken while drilling to ensure that the drill bit is within bone and not skiving across the face of the glenoid. Anchor placement proceeds from inferior to superior, ending at the 3 o'clock position, or the equator of the glenoid. After the anchor is set, a suture passer is placed through the low portal. The suture passer is then used to pass another PDS monofilament around the inferior labrum and portion of the anterior capsule. The PDS monofilament and a single limb of the repair suture are then retrieved through the high anterior portal. With the PDS and single repair suture limb now outside the shoulder, the PDS is hand-tied to the tail of the repair suture. Then, the suture passer is carefully removed from the joint, taking with it the opposite PDS limb. By pulling the PDS limb from the low anterior portal, the repair suture will be shuttled through the labral tissue. This may require a gentle tug. Now that both anchor repair limbs are out of the low anterior portal, suture limbs can be tied with a sliding knot. Seen here is a modified Tennessee slider. The sliding knot is advanced to tissue and positioned away from the glenoid with a knot pusher. It is important to use the anterior limb of the sutures as your post, as this will bring the labral tissue closer to the glenoid and position your knot stack away from the articular cartilage. The sliding knot is secure in appropriate position with the knot pusher. In pass-point fashion, both suture limbs are tightened to lock the sliding knot and backed up using half-hitch throws. Suture tails are then cut, and the process repeated proceeding superiorly, ending at the equator of the glenoid. A review of surgical steps will now be demonstrated. The second anchor is placed. A PDS suture is passed within the capsule and around the labrum. The PDS suture and single repair suture retrieved from the high anterior portal. The PDS is tied to the repair suture tail, and repair suture shuttled through tissue and out the low anterior portal. A sliding knot is tied, and labrum reduced to the glenoid. The sliding knot is backed up with 2 half-hitch throws. Finally, suture tails are cut. The final repair can be seen here, with 3 anchors total. The labrum is now reduced to the anterior glenoid, and procedure completed. Thank you for watching this video. Please go to our website at orthonations.org to learn more about our mission and how you can help support our program.